ही स्क्रीन शेअर होते आणि त्यांची व्हिडिओ त्याच्यावरूनच करते फक्त व्हिडिओ
स्पीकर ऑफ
Hello, am I audible now?
Yes, sir. You are perfectly audible.
And my screen is visible?
Yes.
Hello. So today I am going to speak on organophosphorus poisoning. I have a case which is not very interesting, but I thought the topic is very.
The screen is not visible.
Okay, just a minute.
So screen is visible now.
Hello.
Yes, sir. It is visible now.
Okay. Actually, organophosphorus is a common problem which we all face. And I thought let us discuss some common issues at the bedside where we usually have some problems. I just wanted to revise some of the knowledge of OPP and some controversies regarding the management of organophosphorus poisoning. This case recently got admitted with us. Elderly male has ingestion of OP compound, that is monocrotophos. Quantity was unknown and he was found by the relatives at around 4:30 p.m. at home. In addition to organophosphorus consumption, he was under influence of alcohol, and they too found him conscious with vomitings, 2 episodes, and they took him to the hospital, and he was quite stable. So the doctor at his place discharged him with some medication. He was actually a patient of chronic liver disease since almost 10 years, having ascites, very chronic alcoholic of almost 40 years, and even tobacco chewer. When he was discharged at home, he had 2 episodes of general tonic-clonic conversion, and he was again taken to a private hospital in a post-ictal state. He received anticonvulsants, and then on day 4, at his place, he developed a ventricular tachycardia with cardiorespiratory arrest, and he was given a cardiopulmonary cerebral resuscitation, that is a CPCR was given with a DC shock and injection amiodarone. The return of spontaneous circulation was achieved, and then he was intubated during the CPR and put on a mechanical ventilator, and he received this primary treatment, and these 3-4 days of very critical ups and downs, convulsions and VT arrest and CPR, he was shifted to MGM hospital in our MCR ICU. Actually, what I wanted to highlight at this moment of time is that patient was alcoholic with chronic liver disease. He had convulsions, ventricular tachycardia. In addition to that, he has consumed organophosphorus poisoning. So completely a mixed picture, not a purely OPP patient having convulsions and required ventilation. He continued to have poor condition on admission, tachycardia with normal blood pressure. Respiratory rate was 30. He was on pressure control mode. He was maintaining saturation on only 40% FiO2 with 5 PEEP. Systemic examination, that is chest was clear, heart sounds were normal, but he was drowsy, arousable and obeying commands with moving all 4 limbs. Pupils were bilateral equal, 4 millimeters, reacting to light. He received a routine treatment of ICU admission of a ventilated patient, that is antibiotics. Then he was on Levipil, levetiracetam for his convulsion, pantoprazole. He received atropine to some extent before shifting to our hospital, and he was quite irritable and alcoholic, so he was on Librium, 25 milligram 3 times a day, AT1 and HS, and he was having some fluctuation in BP, and he was shifted on Noradrenaline. Fortunately, we could extubate him after 8 days of admission, but his breathing was not adequate. His muscles were actually, he was using axillary muscles, and he was having secretions too. So we put him on a NIV after extubation and observing for a couple of hours. But unfortunately, he required reintubation due to his muscle fatigue and drowsiness next day morning. Again, he was weaned off and extubated after 5 to 7 days of supportive care in an ICU. Again, he was intubated in view of hospital-acquired pneumonia with septic shock and required Norelin and vasopressin. Again, he was given broad-spectrum antibiotic, which covers Pseudomonas and Acinetobacter, and then shock improved and he was extubated. So he was having a stormy course in his hospitalization. He was having hoarseness of voice and disorientation. He was having alcohol dependence like syndrome. He was quite delirious during his ICU stay. So he was started on treatment under supervision of psychologist, haloperidol, lorazepam, olanzapine, and he was discharged home after medical treatment after 1 month of his hospital admission. So on conclusion, this was a mixed type of case where patient came with a history of OPP consumption with alcohol intoxication, underlying chronic liver disease with probably a withdrawal syndrome or alcohol dependence syndrome. And he developed hospital-acquired pneumonia in between. So the discussion whether he was only OPP, which was the problem for his ICU admission, or in addition to OPP, he was having alcohol intoxication, or both. Probably in this case, I think he had got both the problems. He got some organophosphorus consumption effects, and with alcohol intoxication and alcohol withdrawal too. He had a ventricular tachycardia and an arrest before shifting to our hospital. Again, arrhythmias are quite common with OPP. It is quite common with sometimes alcohol intoxication. It may be because of hypoxia or sometimes drug induced, like some anticonvulsant even causes arrhythmias. But he was on Levipil, so probably Levipil is not a cardiotoxic drug. And what was the cause of his reintubation? That was a point to be noted. So let us revise our old knowledge about the organophosphorus compound. Organophosphates and carbamates are potentially cholinesterase inhibitors capable of causing severe cholinergic toxicity following either cutaneous exposure or inhalation or ingestion. This organophosphates and carbamates, though structurally distinct, exhibit similar clinical manifestations with toxicity and require a similar kind of management following overdose. So organophosphate have been used as an insecticide in worldwide for more than 50 years. Recently, this agent use has been declined with development of carbamate, but having similar toxicity. Organophosphates inhibit both plasma cholinesterase and acetylcholinesterase. Acetylcholinesterase enzyme is found at neuronal synapses in central nervous system as well as peripheral nervous system. Its main function is to hydrolase the acetylcholine. When acetylcholine esterase has been inactivated, its inhibition leads to accumulation of acetylcholine at all throughout the autonomic nervous system, somatic nervous system as well as brain, resulting in overstimulation of muscarinic and nicotinic receptors. So if you see, this is the presynaptic neuron and this is postsynaptic neuron. This is the acetylcholine. This is the black boxes that are acetylcholine, and this is green are acetylcholine receptors. So this acetylcholine binds to the acetylcholine receptor and the signal is generated. Cholinesterase stops the signaling process. So when patient consumes OPP-like compound, it blocks the acetylcholine and the signal is stopped. And in presynaptic, OPP inhibits the acetylcholinesterase and it overstimulates the postsynaptic neurons, and patient gets manifestation of cholinergic crisis. Even this organophosphate compound is separately used in some medical conditions, reversal of neuromuscular blockage like neostigmine, paralsigmine, endorphin, and treatment of glaucoma, myasthenia gravis, and even Alzheimer's disease. Clinical features of organophosphorus poisoning is depend on onset and duration of acetylcholine inhibition. It depends on the organophosphate agent's rate of inhibition of acetylcholinesterase. So how fast or how slow this organophosphate agent acts on AC inhibitors, acetylcholinesterase. Then route of absorption, enzymatic conversion to active metabolites, and whether this agent is lipophilic or water soluble agent. Interestingly, lipophilic agents such as dichlorphentheon, phentheon, and malathion are associated with delayed onset of symptoms. That is almost up to 5 days. Otherwise, all other patients get symptom within few hours of OPP consumption. And this lipophilic agent causes prolonged illness, almost greater than 30 days, which may be related to rapid adipose fat uptake and delayed redistribution from the fat stores. So sometimes we have observed that patient takes very long time to recover from his neuromuscular weakness and even central nervous system manifestation. This is because probably the agent is lipophilic, and we should not actually give up when patient is taking a prolonged recovery from organophosphorus poisoning. So there are a lot of parasympathetic, sympathetic, somatic, and CNS manifestation of this organophosphorus poisoning. The muscarinic signs are easily remembered with two mnemonics, that is sludge BBB. Sludge BBB means salivation, lacrimation, urination, defecation, gastritis, emesis, bronchorrhea, bronchospasm, and bradycardia. And dumbbells is another mnemonic where it actually denotes defecation, urination, meiosis, bronchorrhea, bronchospasm, bradycardia, emesis, lacrimation, and salivation. So it is easy to remember this muscarinic signs with sludge BBB and dumbbells. The nicotinic effects, they are actually fasciculations, muscle weakness, and paralysis via acetylcholine stimulation of receptor at neuromuscular junction. Nicotinic and muscarinic receptor are also have been identified in the brain and may contribute to central respiratory depression, lethargy, seizures, and coma. So, muscarinic effects, nicotinic effects, central nervous effects are very common with OPP compounds. Even cardiac complication can occur with this compound. Cardiac arrhythmias, including heart blocks, QTC prolongation, are occasionally observed in OPP, and even sometimes arrhythmias are because of whether these arrhythmias are because of direct toxicity or secondary hypoxemia is not yet clear, but arrhythmias and cardiac complications are quite common in this compound. Then respiratory failure occurs from combination of depression of central nervous system center, neuromuscular weakness, excessive respiratory secretion, and bronchoconstriction. So most of the patient with a severe disease require intubation and ventilation. The fatalities also occur due to cardiovascular collapse. Although mechanism of this dysfunction is not completely understood, inappropriate vasodilation may play a role. So usual fatality of OPP occurs because of respiratory failure and cardiovascular collapse. The intermediate syndrome, which we all learned since our undergraduate and postgraduate, it occurs between the cholinergic syndrome, that is initial cholinergic crisis, and late onset peripheral neuropathy. So in between these two extremes of the syndrome, this intermediate syndrome occurs. The incidence is almost 10 to 40% in OPP consumption. It usually occurs after 24 to 96 hours of exposure to the poison. It reflects prolonged action of acetylcholine on nicotinic receptors. The clinical features are muscular weakness, particularly ocular and neck muscle weakness, bulbar, proximal limb and respiratory muscle weakness, decreased deep tendon reflexes, then cranial nerve abnormalities, proximal muscle weakness, respiratory insufficiency. So basically, ocular, bulbar, neck muscle weakness with weakness of respiratory muscles and proximal muscles is a prominent manifestation of this intermediate syndrome. What are the risk factors? This risk factor for the development of intermediate syndrome appears to include exposure to highly fat-soluble organophosphorus agent that may relate to inadequate doses of, and second is inadequate dose of oximes. So oximes are very important to prevent intermediate syndrome. The risk of mortality due to respiratory depression as a result of muscle paralysis. Nerve conduction studies on patients with intermediate syndrome reveal unique postsynaptic abnormalities that differentiate this disorder from delayed neurotoxicity. So intermediate syndrome has risk of mortality due to respiratory depression and muscle weakness. And if you don't give oxime adequately, then chances of intermediate syndrome increases. Then third complication or effect of this organophosphorus compound is delayed neuropathy, or opioid organophosphorus agent induced delayed neuropathy. Typically occurs 1 to 3 weeks after the ingestion of one of the small number of specific organophosphorus agent, including chlorpyrifos. Again, this trichlorcrystal phosphate and tricrystal phosphate, these are two compounds which are quite commonly cause delayed onset neuropathy. On ingestion, they do not produce significant cholinergic crisis like all other agents. The mechanism may involve inhibition of neuropathy targeted esterase rather than alteration in RBC acetylcholinesterase function. Affected patient present with transient painful stalking glow paresthesia followed by symmetrical motor neuropathy, polyneuropathy characterized by flaccid weakness of lower limb which ascends to involve upper limbs. EMG and NCV studies of such patient revealed decreased firing of motor conduction units. So this is about the delayed neuropathy. How to diagnose OPP? It is very obvious. It is a clinical diagnosis based on the syndromic approach and the history, where patient tell the history or relatives bring the bottle of poison which is consumed by the patient. So most of the time diagnosis is very clear. Then you know there is a particular smell of organophosphorus poison, that is like garlic like smell, which is quite obvious that patient has consumed something like organophosphorus compound. Just to recapitulate, pupillary signs are always important in any of the poisoning. Just to enlist the causes of meiosis, that is organophosphate or carbamate, narcotics, barbiturates, phenothiazines, clonidine, and phencyclidine. This causes constriction of pupil, while mydriasis is caused by atropine, LSDs, MAO inhibitors, nicotine, amphetamines, antihistaminics, and tricyclic antidepressant. So whenever you are confused about the diagnosis of poison, pupillary science gives you some clues. So most of the clinicians usually do the cholinesterase levels. I'm always having a doubt whether this really helps in our diagnosis and management of patients with OPP. I probably never done this test to my patient with OPP. So does it help really to diagnose the organophosphorus compound? Whether we should do a plasma acetylcholinesterase or RBC cholinesterase? Does it correlate with the severity of the disease? Does response of therapy can be assessed with these levels? And whether it correlates with the outcome? These are the few questions about this test. So confirmation of OPP is based on the measurement of cholinesterase activity. Typically, these results are not readily available in clinically relevant frame time. So we want to do a test to confirm. Yes, definitely, it has got some role to diagnose the OPP, but you should get the report within time. Although RBC and plasma pseudocatalytic levels can both be used, RBC cholinesterase correlates better with CNS acetylcholinesterase and is therefore more useful marker for organophosphate poisoning. So there are differences between plasma and RBC cholinesterase. RBC cholinesterase represent the acetylcholinesterase found in RBC membrane, similar to that found in the neuronal tissue. Therefore, measurement is more accurately reflect the nervous system organophosphorus acetylcholine inhibition. Plasma cholinesterase is a liver acute phase protein that circulates into the blood plasma. It is found in CNS white matter, the pancreas, and the heart. It can be affected by many factors like pregnancy, infection, and medical illness. Additionally, a patient's level can vary up to 50% with repeated testing. So that's why plasma cholinesterase, which we usually do, is not reliable test. Again, this is a comparison between plasma and RBC cholinesterase levels. Plasma levels, they can easily assess and available. The response to antidotal therapy, that is antidotal therapy, is unlikely by this assessed by these plasma levels. And this altered, as I told you, in malnutrition, chronic illnesses, chronic liver disease and infection, even in patients with pregnancy. Red cell acetylcholinesterase, it is not available readily to most of the people in our country. So it is difficult to assay, but it correlates well with the neuronal activity. If 30% activity, the normal muscle function, but it is with less than 10% activity, we can judge that patient has got grossly deranged muscle function. Increased activity after oxime therapy is quite correlated with RBC acetylcholinesterase. So you can judge to some extent the effect of oxime and improvement in the patient with red cell cholinesterase level. This also alters with hemoglobinopathies and thalassemia. So this is, I think, we usually don't know the difference between plasma and RBC cholinesterase. The measurement of RBC and plasma cholinesterase levels prior to treatment with palidoxime can be used to determine the response to therapy. If we do a serial RBC or plasma cholinesterase, to some extent we get response of therapy can be assessed. RBC cholinesterase is the more accurate of the two measurements, but plasma cholinesterase is easier to assay and more readily available. The cholinesterase level do not always correlate with the severity of clinical illness. This one paper, original research paper by Indian author, the relation of serum cholinesterase with clinical severity and treatment outcome of OPP in tertiary care center, a prospective study. The conclusion of the study was clinical severity was associated with treatment outcome. So the treatment outcome is totally dependent on the clinical condition of the patient. No particular trend of association was observed between the clinical severity and the serum cholesterol level. So serum cholesterol level had shown no association with the outcome. So outcome benefit is not with this test. Again, this is a test, it is a paper to determine whether serum cholesterol level has prognostic value in human acute organophosphorus poisoning. Again, the conclusion is these levels have no prognostic value in acute OPP. This grading system identify high risk patient based on the measurement of the most likely unreliable. So grading the severity based on the cholesterol level is highly unreliable. So particularly if you want to take home message about the cholesterol level, to some extent it can give you diagnosis when in doubt, and it can also give you some clues about the effect of your therapy, particularly oxime therapy. Otherwise, severity not reliable, prognosis not reliable, outcome not reliable. Atropine, I think we are using atropine for almost all OP patient without any hesitation. But remember, atropine is very important and life-saving drug in organophosphorus poisoning. Let us learn something more about the atropine. As you all know, it is a physiological antidote. It antagonizes the muscarinic receptor mediated actions of excessive acetylcholine. Atropine actually competes with the acetylcholine at muscarinic receptor and preventing cholinergic activation, but it has got little effect or no effect on nicotinic receptor. It blocks excessive tracheobronchial secretion, bronchoconstriction, salivation, and bradycardia. And it counteracts the effects of acetylcholine in the central nervous system. So definitely, this is very important drug and must be given as early as possible. So something about the dose, duration, and atropine toxicity. For moderate to severe cholinergic toxicity, atropine should be administered at the beginning dose of 2 to 5 milligrams IV for adult and 0.05 milligram per kg for children. If no effect is noted, the dose should be doubled every 3 to 5 minutes until the pulmonary muscarinic signs and symptoms are elevated. Atropine dosing should be titrated to the therapeutic end point of the clearing of respiratory secretion and cessation of bronchoconstriction. So this is from up to date. What they said that atropine dosing should be titrated depending on the clearing of the respiratory secretion and cessation of bronchoconstriction. Tachycardia and mydriasis are not appropriate markers for therapeutic improvement, as they may indicate continued hypoxemia, hypovolemia, or sympathetic stimulation. So remember, our usual method of targeting heart rate for dosing of atropine is not a reliable way. In patient with severe poisoning, hundreds of milligrams of atropine by bolus or contained infusion may be required over a course of several days. For patients who do not respond to high doses of atropine, sometimes we may think of adding epinephrine. Toxicity, which includes flushing, dry skin of dry mucous membranes, tachycardia, widely dilated pupils that are poorly responsive to light, blurred vision, and high-grade fever. Sometimes it is dangerously elevated. So these are the signs of atropine toxicity. And we must have, I think everybody in the group must have seen this atropine toxicity whenever we are treating organophosphorus patient. Patient also get locomotor difficulties, disorientation, hallucination, delirium, confusion, agitation, coma, and CNA depression can occur and may last for 48 hours or longer. In instances of severe atropine intoxication, respiratory depression, coma, circulatory collapse, and death even can occur with atropine toxicity. Treatment of toxicity is supportive. If there is a respiratory depression, artificial ventilation, oxygen, fever can be controlled with ice bags, alcohol sponges, hypothermia blanket may be required. Catheterization may be necessary for urinary retention. Since atropine is eliminated, elimination takes place through the kidneys, urine output must be maintained and monitored and increased if possible. However, dialysis has not shown to be helpful in overdose situation. So give intravenous fluids when indicated. Because of atropine-induced photophobia, the room should be darkened. Benzodiazepines may be needed to control the marked excitement and convulsions. Barbiturates are potentiated by anticholinergic. Therefore, barbiturates should be used cautiously in treatment of convulsions. Central nervous system stimulants are not recommended for atropine toxicity. Glycopyrrolate is another compound which probably compared with the atropine. Since glycopyrrolate does not enter CNS central nervous system, initial muscarinic signs like coma or drowsiness will not respond to the glycopyrrolate. It is recommended when there is a copious secretion and it should be used in adjunction with the atropine. When features of atropine toxicity like delirium, are confused with CNS effect of poison, then we can stop atropine and give a glycopyrrolate. So in this condition, you can think of giving glycopyrrolate. And unfortunately, if atropine is not available or stock is exhausted, till that time you can use glycopyrrolate. But it should be used as an adjuvant rather than replacement to the atropine. The dose is 7.5 milligram glycopyrrolate in 200 ml of normal saline started as an infusion and is titrated to the desired effects of dry mucous membrane. So comparison of atropine versus glycopyrrolate. The conventional treatment with atropine may lead to CNS toxicity, although control of secretion may be still inadequate sometimes with the atropine. There is a randomized controlled trial of 44 patients compare atropine with glycopyrrolate, a drug that may provide better control of secretion and does not cross blood-brain barrier. Grading was performed prospectively and compared the outcome. 39 cases were evaluated, out of which 22 patients received atropine and 17 received glycopyrrolate. No differences could be detected in outcome except for the trend to fever respiratory infection in glycopyrrolate group. Thus, the treatment with atropine and glycopyrrolate was equally effective. Then, role of palidoxamine. Since atropine does not bind to nicotinic receptor, it is ineffective in treating the neuromuscular dysfunction. And you know, most of the patients require respiratory support because of neuromuscular effects or central nervous system effect. So palidoxamine and other oximes are cholinergic reactivating agents that are effective in treating both muscarinic and nicotinic symptoms. Palidoxime should not be administered without concurrent atropine in order to prevent worsening symptoms due to transient oxime-induced acetylcholinesterase inhibition. So, PAM should be used with atropine or after atropine. Oxime therapy be given to all patients with evidence of cholinergic toxicity, patient with neuromuscular dysfunction, or patient with exposure to organophosphorus agent known to cause delayed neurotoxicity. As I told you, there are some organophosphorus compounds which are known to cause delayed neurotoxicity. If this compound is been told by the relatives or by the patient, then we must use oxime therapy to prevent a delayed neurotoxicity. Its major effect is on peripheral nervous system and it does not cross blood-brain barrier. The current WHO recommendation for IV bolus therapy with palidoxamine is at least 30 mg per kg in adult and 25 to 50 mg per kg for children based on the severity of symptom. Although no treatment have been shown to prevent intermediate syndrome or delayed neuropathy, early oxime therapy may be benefit in this situation. Doses of oximes are administered as an infusion, which should be continued until recovery. That is 12 hours after stopping administration of atropine or once butyryl cholinesterase is noted to be increased. The palidoxamine chloride, which is the most commonly available oxime to us, the loading dose is 30 mg per kg intravenously over 20 minutes, followed by 8 mg per kg per hour. till patient recovered. So this is a dose. In adults, it is usually given 2 gram loading dose followed by 500 milligram per hour. So remember, the dose is very important as far as the pyloxamine chloride is concerned. So this is about the common issues in managing organophosphorus poisoning. The case was not very complicated to discuss, but what I thought, the atropine, which is a very common drug, we should know how it should be used, when it should be used, what are the side effects, and how we can manage atropine toxicity. That is number one. Cholinergic levels, which usually are not useful in when diagnosis is obvious, and it has got very little role in assessment of severity and outcome. So as a take home, it is not really required in most of the patient. And PAM is important drug which actually reverses the neuromuscular effects of the poison, and it should be continued as long as patient requires it, and it should be given after atropine, and it should be stopped after atropine is stopped. That is what I can probably add into your knowledge of organophosphorus poisoning management. Thank you. And if any questions, please put your questions in the chat box.
Hi, sir. Hello. Am I audible, sir?
Hello.
Sir, sir, I think case was more related to alcohol rather than organophosphorus.
Yes. I agree with you, Sharad. Actually, we had a couple of cases of organophosphorus poisoning, but ultimately this case we selected to discuss. But this was more of a alcohol intoxication.
Yes,
And probably post cardiac arrest case with, I think, some effect of intoxication and some effect of probably hypoxemic encephalopathy, which we manage in the ICU. But one thing is very important when I revise about this patient probably had delayed neurotoxicity, because he required intubation 2 times of his admission after 8 days, first extubation and intubation, and even after second extubation, he required re-intubation after 7 to 8 days. And it was not only a pneumonia and tachypnea which actually made us to intubate him, but he was having a neuromuscular weakness in addition to his respiratory type 1 respiratory failure. So probably he had delayed neurotoxicity secondary to organophosphorus poisoning. And what I wanted to highlight, Sharad, here, that I've seen many patients when they remain unconscious for long on a ventilator. We sometimes try to lose the patients because relatives are asking when patient will recover. And cost matters when patient gets prolonged hospitalization, maybe couple of weeks or 3-4 weeks of ICU admission on ventilator. But delayed toxicity, even central nervous system toxicity like lipophilic agents, and delayed neuromuscular weakness is known with organophosphorus poisoning, and we should not give up such patient. That is one thing. And I think we are using PAM in a very different doses. Somebody is using 500 8 hourly, 1 gram 8 hourly, I'm using 500 milligram hourly after 2 gram bolus. So there are a lot of variation in the doses. So whatever I could gather from the standard references, that is, one is up to date, second is Medscape, and third is WHO references. So they recommended that 2 gram bolus followed by 500 milligram per hour, as long as patient requires it. Relatively, that drug is quite cheap.
Sir, good evening.
Good evening, good evening.
Sir, I want to ask one question.
Huh.
For how many days we continue PAM to, take care of the intermediate syndrome?
See, intermediate syndrome has no medical treatment.
Okay.
Only supportive treatment.
Okay.
You just put your patient require intubation, intubate him, and give supportive treatment.
Okay. But for how many days we need to continue paradoxime on the PAM? When you start
the recommendation is that once you stop the atropine, after 12 hours of that, you can stop PAM. I'll just go back to my slides again.
Okay, sir.
Can you see my slides?
Yes, sir.
So they are administered as an infusion, which should be continued until recovery. That is 12 hours after stopping administration of atropine. Or if you are the acetylcholinesterase level, that level should increase to the almost normal level.
Yes, sir. Thank you.
Yeah.
Hi, sir. Hello.
Hello. Niraj.
Yeah, sir. Atul here.
Atul, sorry. Atul.
Yeah. Sir, I have two questions. One is that some physicians, they tap on the calf muscle and shoulder to see for induced fasciculation. So whether it is justified to see induced fasciculation or spontaneous fasciculations are important. And the second thing is, in our case, we have given haloperidol. The patient has arrhythmias. Haloperidol itself can cause QTC prolongation. So whether it is justified
Yes. Yes, your question is right. I think being now you are a neurophysician, you are in better position to tell which fasciculations are important.
Yes, in motor neuron diseases, we see spontaneous, sir. In this case, when there is neuromuscular junction, so that I'm not aware whether there is any other mechanism to induction.
Actually,
causes.
this is our traditional clinical teaching to elicit the fasciculation to see whether fasciculation is present or not. But if there is spontaneous fasciculation, there is no need to elicit the fasciculation. That is one thing. If spontaneous fasciculation are absent, then probably you can see whether fasciculation is present on stimulation or not.
Okay.
Yeah. And of course, pro-arrhythmic drug should be avoided in this patient. But incidentally, the one episode of VTAC before admission, and then he did not have any cardiac issue. In fact, his 2D echo and top T, all these reports were normal. But yes, we should always consider side effects of the drug, particularly antipsychotic drugs when probably there is a cardiac toxicity.
Okay.
Palm in this case.
Yes, Dr. Dixit is asked about the decontamination of gastric lavage. If patient presents early, probably within an hour, and every management should be priority, along with atropine priority. He is 100%, I think, correct. I have not gone to the detailed management of the OPP, but decontamination of skin, decontamination of gastric content.
How many times?
Is very important. Remember, the absorption takes place from the skin and GIT and inhalation. So initial hours, maybe first 24 hours are important. After that, probably it is all absorbed poison. So in first hour, definitely major role is of decontamination. and it should continue for early 12 hours to 24 hours.
Role of charcoal.
Yeah. Charcoal, yes, of course it is available. You can use it for organophosphorus poisoning compound also.
Sir, have you used palm in this case?
We are not used palm because he was not having actually signs of neuromuscular weakness, and he came 4 days after his
Yes.
onset of consumption.
Okay, so I think sir, everything is related to alcohol intoxication and withdrawal maybe.
Yes, yes,
And
yes.
someone had given maybe atropine that have precipitated tachycardia because on admission pupils were dilated 4 millimeter,
Correct,
and
correct,
he was having tachycardia. So more of alcohol related, and after that maybe he was chronic alcoholic and cirrhotic. So we have given to control everything. We have given sedation and all that may have precipitated the neuropathy, maybe critical
yes.
illness or alcohol related neuropathy.
Yes, quite possible. Actually, I just wanted to discuss a common organophosphorus compound related issues like atropine, palm, which usually we
Yes.
overlook. So case was just to have a discussion about the organophosphorus poisoning. It may not be clearly organophosphorus related complications of this patient, but this patient ultimately survived whatever ups and downs he had during hospitalization. But as you said, it may be a more of a alcohol intoxication with some side effects of drugs. We could not actually, we are not given atropine and palm to this patient on admission. Atropine
Yes.
hardly we are given. Yeah.
Sir, palm I was using actually 2 gram stat and 1 gram 8 hourly. I was not knowing that it is given hourly because
Yeah, actually, no. Actually, I'm in discussion with Dr. Dilip Punde and Himadra Boiskar for calling them for a workshop on poison. One more
Yes.
name we should remember, that Dr. Pawar from Baramati. She
Mhm.
is one of the authority in organophosphorus poisoning, and her paper on palm was published almost 10 years back in Lancet.
Mhm.
And what she recommended, she compared 500 milligram hourly dose with 1 gram hourly dose, and she found the recovery is much better when we use 1 gram hourly um, palm in this
Okay.
patient.
Oh,
And she is a member of ISSM, and she is in touch with me. I attended one conference with her in Germany. So if possible, we'll call her to talk on OPP poison when we actually plan a workshop in Aurangabad.
yes, sir. Definitely, sir.
Yes, yes.
Thank you, sir. Thank you so much.
Thank
Good
you.
evening, sir.
Madam. Madam, good evening.
Yeah, just to highlight the same dose thing, whether we should recommend it in an infusion form or in a bolus form.
Palm, na?
Yeah, palm.
Yeah, palm is bolus initially. Loading dose is 2 gram bolus.
Yeah,
And
but
then
later
it
on the
is-
maintenance dose, because
Yeah.
initially they had done some studies of continuous infusion versus boluses.
So what I got from up to date and WHO and Medscape guidelines, they are given bolus followed by infusion.
Okay, okay.
Yeah.
So that's a continuous infusion till the patient recovers.
Yeah, till the patient recovers.
Yeah, thank you.
I think Madam has got more experience of managing poison. Madam and I think Dr. Dixit both actually manages many patients of poison in their area. So their input is really important for everybody. Anything additional you want to comment on the madam about this OP
Sir,
poison?
recently this month we are seeing a lot of patients who are having intermediate syndrome as a, which we used to say intermediate, now we are seeing very commonly. The patient is in ward again deteriorating and having intermediate syndrome. So we don't know whether the
I think,
lipophilic compound is more or the poisonous compound is more toxic.
madam, I'll request you one thing. Actually, ISSM has actually formatted a committee of making guidelines at national level on poisoning.
Yeah.
And I am one of the member of that committee.
Okay.
And we decided to accumulate the data from various parts of the country. So you please keep data of your patients. We'll soon share the Excel sheet where we can store data, and we'll form a common standard guidelines. And we are in process to have a helpline number where 24 hours some expert will give a feedback about the treatment of poisoning, diagnosis of poisoning, and what we can do for the patient. So what probably intermittent syndrome which you are seeing, you must analyze whether the patient came within few hours of ingestion or they are coming late, and which particular agent they are consuming. So on the basis, we'll probably find out, and the palm definitely has role to prevent intermittent syndrome to some extent. And again, diagnosing intermittent syndrome and managing with effective ventilation and supportive care is important, because most of them will recover.
Yes. Yes. True.
Yeah.
Thank you, sir.
Thank you. So let us continue such discussion in between. Now we are off COVID now, and we may have some physical meetings henceforth. But I think this is very convenient online meetings, because you can actually join from your home or office or cabin in the hospital, and we can get connected without traveling and without wasting much of time in other things. So I really thank Poland Pharma for pushing me to take such cases. This was actually a case we had taken after 2 months of break. But we'll try to continue the cases, and I encourage everybody. It is not like Dr. Nikalje should only present the cases. Madam Kavra Madam, Dixit sir, Baryada sir, even Atul, you can come forward, and I think we can discuss some interesting cases from your side also.
Yes, sir. Yes, sir.
And this is a very, very informal kind of group. So nothing, actually, we should discuss as a friend rather than having some hesitation in presenting the cases. So I'm also encouraging my intensive care team members to come forward and present the case next time. I think every time we learn few more things. Though we are managing patients very frequently, like organophosphorus poisoning, but when I gone through the literature, I always gain some more knowledge. Some knowledge is revised, and we become more confident in treating such patients. So I think that is a take home for today's lecture. And thank you, everybody. Have a nice weekend.
Thank you, sir.
Thank you.
Sir, something really good.